G'day, mates. Today we have a special guest, Dr. Ryan Nord. Dr. Nord is an associate professor of otolaryngology. Did I say that right?
Nice job.
Yeah,
Yeah.
perfect. At VCU Health in Richmond, Virginia. And he's here today to share his experience treating sleep apnea with the Inspire Hypoglossal Nerve Implant. Dr. Nord, warm welcome to the channel.
Thank you so much. Thank you for that warm introduction. Happy to be here.
Now, perhaps you can start by telling the audience about your professional background, how long you've been treating patients with Inspire, and what activities you enjoy when you're not in the operating room.
Awesome. Yeah. Well, I've been in practice for about 8 years, and I'm in Richmond, Virginia, and I practice at VCU, like you said. So that's kind of the main medical school in Richmond. And my practice is primarily around treating people with sleep apnea. So sounds like we have that in common, and it sounds like a lot of your viewers that they're really engaged in that space. But my clinic is it's really focused on seeing those people who are struggling with CPAP, or maybe have tried it for some time and just haven't been able to tolerate it well. And so, I offer them a variety of solutions. Hypoglossal nerve stimulation or Inspire is one of those solutions. And like I said, I've been doing that, the Inspire procedure for about 7 years, and have done just about 400 of those procedures. When I'm not in the operating room, I'm hanging with my kids, my wife and kids. I've got a 10-year-old girl and a 5-year-old boy, and recently picking up tennis. So, yeah.
Hey, there you go. Any golf? Any fishing?
No golf or fishing,
You're never too late for those activities.
as far as my tennis game goes, I don't know that I would do any better with golf. I'm trying to stick with one thing.
Now, there'll be plenty of people watching who have never heard of Inspire before. So perhaps you could talk just a bit about the device and how it actually treats sleep apnea, because it's quite different to positive airway pressure.
And I think, one thing I'd like to just kind of get out of the way from the start is, this is not about CPAP versus Inspire. Very different treatment options, and we always go for CPAP first.
Okay.
So we're never taking patients who are doing great with CPAP, are treated well, and say, here, let's try this, invasive surgery and put in this medical device in you. So I think let's start with that. It's for people who, for any number of reasons, are just not able to be successful with CPAP. And so I think it's a nice opportunity to have another option, have another treatment.
Absolutely.
Yeah. And I watched some of your videos on the channel, and it's amazing how in depth you get with looking at the data and troubleshooting. And so it's an amazing resource to have for patients. So congratulations on that.
Thank you very much.
To answer your question about just kind of explaining the basics of
Yep.
hypoglossal nerve stimulation, the way I explain it to my patients is that it's like a pacemaker for your breathing. So it is a medical device. I don't know if you've seen any of these commercials that Inspire puts out there, but
I
sometimes it
have.
can, yeah,
They're
sometimes
quite
it can,
good.
yeah,
They're quite
it can
funny.
oversimplify things a little bit, maybe.
Yeah.
So we always got to start with, okay, this is a surgery. Like, in the operating room, you're completely asleep, and it's basically the way it works is by sensing your breathing and then stimulating a nerve in your neck that controls your tongue.
Okay.
And so the idea is that every time you're breathing in at night, it will sense your breathing and slightly push your tongue forward, which will then relieve the obstruction or prevent the obstruction from happening in the first place, and keep you breathing normally at night.
All right. Now take me on the patient journey. I've just thrown my CPAP off the cliff and I'm on my way to your office. What's first? Who's the ideal candidate for Inspire? What are the criteria for recommending the treatment? And are there any specific tests or assessment required pre-surgery?
Yeah. I mean, it starts first with a conversation. What are the
Yep.
patient's goals? What are they trying to get out of this device? We need to have realistic expectations. One of the things with CPAP is that if you can use it and wear it all night, typically your AHI numbers are going to be quite low. You're talking about probably curing a lot of people's sleep apnea with CPAP. So
Definitely.
with Inspire, on the other hand, we might be looking at a 70% improvement, maybe a little bit higher. It's a heck of a lot better than not doing anything.
Yep.
But again, it's not going to be quite as good as CPAP. So we talk about expectations and making sure that they're realistic about what to expect. Typically, the apneas do get a lot better. Typically, the snoring gets better, but might not get resolved, and people feel better. Once they're kind of on board with those expectations, of course, we're going to do, a kind of a full history, sleep history, and a physical exam, look into their nose and throat, and kind of see if there's any other sources of, blockage, anatomical issues that might
Right.
have to be first.
Yep.
Assuming there's not, from there, they actually undergo a endoscopy procedure first, which we call a DISE, DISE, which stands for drug-induced sleep endoscopy. And basically, you put someone to sleep, and it's kind of cool because you can use a small little camera from their nose, look into the different levels of their throat, and actually see where the problem is.
Right.
So,
And is it a lot of the time down, sort of, at the tongue area, or is it sort of sometimes up here?
surprising that it can be really different for different people. So not everybody's a candidate for Inspire based on that exam. Some
Right.
people, it may be that like the sides of their throat are squeezing in, wouldn't be really well treated with Inspire, whereas other people might have their tongue falling back more. And if you imagine the device pulling your tongue forward, and it's kind of reversing the problem.
Yep.
So those are really the best candidates.
Is there a way to sort of, when you're doing this dice, can you pull the tongue forward and actually see what happens to the airway?
That's a really smart and intelligent question, and you're already thinking like like a physician and a surgeon, I can tell. So, we can do little maneuvers like slightly thrust their jaw forward or even pull on their tongue, like you said. So far, those haven't really helped us pick even better people. We can, based on the endoscopy, normally tell somebody that you're a great candidate, you're kind of a fair, okay candidate, or you're not a candidate at all.
Okay.
And so, we can't certainly say that you're 100% going to have a successful outcome. But for those people, like I said, their tongue's falling back. Thinner people do better than heavier people. Actually, older people do better than younger people. It seems like women do a little bit better than men. So those are some of the other factors we look at.
Yeah, that's really interesting.
In my own patients and my own data, for those good candidates, we can say that it's about 85% chance of a success. If you kind of line up with those things of your tongue is falling back, it's not the sides of your throat squeezing in, for instance.
So can you walk us through the procedure from start to finish? How invasive is it? And what is the typical duration of the surgical procedure, but also the recovery afterwards?
Sure. So the surgical procedure, it's outpatient. So the patients are going to expect to come and go that same day. The
Wow.
actual surgery from start to finish takes anywhere from about an hour to an hour and a half for most experienced surgeons. It's going to be done most of the time on the right side of the body. Reason being is we reserve the left side in case people need like a pacemaker down the
Gotcha.
road.
Yep.
In terms of the invasiveness, and again, the patient would be completely asleep, so it's general anesthesia. There's 2 incisions. One is going to be right under the jaw, and it's about a 3 centimeter incision. And then one is going to be just below the clavicle, and that's going to be about a 4.5 centimeter incision. So the way that the surgery is done is that up in the neck incision, we find that nerve, the hypoglossal nerve, which is the nerve that controls the tongue. And, as you can imagine, your tongue has different muscles.
Mm.
Some of the muscles will push the tongue forward. Some of them will pull the tongue backwards. We want to only find and stimulate the part of the tongue that's going to lead to the airway opening. So that's kind of the main technical part of the surgery is we have to separate the different nerve branches and
Wow.
find the branches that will just stiffen and protrude the tongue. And we put a small little electrode cuff around there. It's about 1 centimeter cuff. and we tunnel a wire from the neck to the chest. There's a battery that sits there on top of the chest muscle. And then there's actually a small breathing sensor that fits between the ribs. And so it's 2 incisions, it's a 3-part device. And again, takes about an hour to an hour and a half. Typically just some absorbable sutures and dressings, and then they're good to go. And recovery is typically about a week or so.
Wow. So in and out the same day, recovery 1 week.
Yeah, I mean, again, everybody's different, and I'm sure we'll get into that because I know you want to talk about some of the risks of the procedure and
Yeah,
all
cool.
that. For most people, most of my patients take very little, if any, strong pain medication. They typically do have a good amount of swelling in their neck, but that goes down fairly quickly. They might have a little bit of bruising, but typically they're back to their normal activities within a couple of days, and we just have them take it easy for a week or two.
Yeah. So back to work relatively quickly, though, you'd say for
Yeah,
most people.
yeah, absolutely.
And so just with the wire there, you said sort of tunneling down. How do you get that down there? Just
Yeah, I mean,
poke it on
it's
down.
kind of like you're like electrician putting,
Yeah, that's what I'm
power
thinking.
cord under the wall, right? We actually there's a metal rod that we bend,
Yep.
and we literally tunnel it from the neck to the chest and kind of plug the wire into the top of that rod and then pull it through and kind of snake it through.
And is it sort of going
Um,
between, I guess, your skin and your muscle? That sort of, that's how
Yeah,
you do
just
it. So,
all this tissue here. So
yeah,
it's not real deep into the body.
no,
It's under the skin, and there's also a muscle layer under that skin.
you like are an electrician really because it's an electrical wire there that you're connecting up to a battery system.
Exactly. Yeah.
How long does it sort of take from that recovery before patients sort of start to see the improvements in their sleep? You got to fine tune the electricity
Yeah,
settings. Is that correct?
exactly. So after the surgery, we have to let things completely heal before
Okay.
we turn on the device. So it's about a 1 month period of kind of waiting before we activate the device.
Yep.
So the patient would then typically come back normally to their sleep medicine doctor where the device will be activated. So they put like a little probe right over where the battery or the generator is,
Yep.
and it kind of communicates wirelessly to that. And we just use a little tablet, and we can program the device. So we can
Right.
change how strong the stimulation is, how long each little pulse lasts, in a number of different settings. But in the office, we'll kind of start out with a very slight amount of stimulation because we don't want it to be
Yep.
uncomfortable. And that's when we do a lot of the education about how to use the device, because the patient controls the device at home with a remote.
Mm.
And so them how to use that.
And do they have control over the strength and the duration, like you said before, as well, or is it only from the doctors with the tablets?
Yeah, a little bit of both. They will have control over turning it on and off or pausing it, and they can go up and down levels in terms of how strong it is.
Mm.
And then with the tablet, we can program a number of different other settings, like when you press the button, how long does it delay for to let you fall asleep?
Yep.
How long will it stay on before automatically shutting off, and other kinds of advanced settings. So they go home, that first night, they're going to turn it on. It will delay to let them fall asleep. So normally we'll say 30 minutes between turning it on and the device actually starting to turn on.
Yep.
Because we don't want people to try to fall asleep while it's pulsing over and over at night.
No.
Uh, and then gradually they slowly increase how strong each pulse is, kind of one level per week. And normally people are starting to get benefit after a couple of months or so. So it does take 2, 3 months, sometimes a little bit longer, before people are starting to feel more rested, snoring less, having less apneas, and getting their sleep apnea treated. So it is a fairly gentle stimulation. That being said, again, we've all seen patients, all the surgeons who do this, I've seen patients who do struggle with the comfort of it. It's a patient by patient thing, but most people tolerate it quite well. One of the things that keeps me involved in doing this procedure and in treating sleep apnea in general is just the change in the quality of life of people is dramatic. It's dramatic for CPAP too, as you know. I mean, if you put on your CPAP, all of a sudden you didn't even realize that you weren't sleeping, and it's like a whole new world.
Yeah, it
And
is.
yeah, and to see that, for people who had gone through the CPAP process and given it their all, but just never could get successful. But at the end of the day, having that same great feeling of going to sleep and waking up rested, that's what really keeps me involved and engaged in this whole process.
We'll touch on the financials. What I'm after
Yep.
really is just a ballpark figure. The moment someone comes into the office to that 4 months after when they're starting to feel better, what's sort of just a ballpark? Doesn't have to be 100% accurate, and maybe it changes as to just sort of the total healthcare costs involved for everything, surgery, hospitals, patients.
There's different numbers. So I think one number would be the amount that is billed, from the hospital side. One
Yep.
number would be the amount that the insurance pays, and then another number may be the amount the patient pays. And
Okay.
thankfully, those are decreasing numbers. So we've certainly seen some bills. I'm not going to say this from my own institution or not, but these surgeries can bill upwards of $100,000 at times.
Yep.
But most of the time, they're going to be reimbursed somewhere in the $30,000 to $40,000 range. So the surgery itself typically will cost somewhere in the $30,000 to $40,000 range.
Yep.
And a lot of that just comes down to the cost of the implant, which itself is somewhere in the high $20,000 range in terms of the cost of that. And of course, there's several visits like we talked about. You're going to probably need a sleep study if you haven't had one recently, the endoscopy, the surgery, and then the post-op care. So, the total billing for that is definitely going to be in the six-figure range in the United States, at least for many people. Thankfully, the patients, at least from what I've heard, every insurance is different, but normally can be anywhere from $0 up to a few $1,000s.
Wow.
I haven't heard anybody who's been paying tens of thousands of dollars out of pocket.
So where's
And
the
so
gap there between sort of what the insurance pays out and that extra 30, 40,000, whatever it is? How does that get paid?
this kind of gets to the heart of, like, how billing is done in hospitals in the United
If it's
States.
too boring, we'll just move on if you
Well,
want.
no, I mean, it's just a lot of what happens is that you bill a certain amount.
Yep.
It's clearly over what you're going to get paid, and
Yep.
then a certain portion is essentially written off, is my understanding of
Okay.
it.
Yep.
Yeah.
All right, cool. But the good news is for the patient, it's a relatively low cost for the amount of work and everything that's done, the operation, the follow-ups, the testing, all that.
It's going to be probably for most people quite a bit more expensive than using CPAP, and it's certainly on a healthcare scale. It's quite expensive for a country, and so that goes back to why we always consider this to be a second line treatment, and only for people who really can't use CPAP and benefit for it. But you're right, even for people who have Medicare and Medicaid, for instance, in my institution, those people are typically not getting much in the way of any out-of-pocket expenses.
Now, you wrote a paper, and I had a read of it last night, actually, analyzing
Okay.
some of the adverse events reported in the FDA More database. Do you want to just touch on, what your findings were and basically what it's like being on the front line as well? Obviously, you're in the weeds, you're doing this every week.
With any surgery, there's always potential complications, and the hypoglossal nerve stimulation is no different. The paper that we reviewed looked at somewhere in the range of 1,300 adverse events that were reported to the MOD database, which is through the FDA. Of course, this doesn't capture every
Yes.
single small adverse event, or it doesn't capture everything. It relies on the company reporting, the patient's reporting, the physician's reporting. I do think it does a very good job of capturing the major adverse events, things that would require another trip to the operating room. So those type of things would be like a bad infection where the device has to be removed, which happens about 1% of the time, maybe less, but
Okay.
potentially about 1%.
Yep. So less than 1% for full device removal.
Yeah,
Yep.
exactly. You could also get bleeding or what's called like a hematoma. And that may need to go back to the operating room to kind of wash out any blood clot and kind of fix that issue or stop bleeding. And so those were two of the most common things we saw in the MOD database. The other issue that we saw was just pain.
Mm.
Normally pain after surgery is fairly minor. But for these people who reported problems to the database, it could be pain related to the generator itself, to maybe the breathing sensor. And at times that required either revising something with the device or even removing it.
Okay.
So infection, pain, and kind of a hematoma, those were the most common things that we saw in our review of the MOD database.
Okay. Awesome. And what about things coming loose?
Normally it stays, in place. So it's a little cuff that's around the nerve,
Yep.
and then there's a loop of wire, and then there's two little areas that we can sew a stitch down to a really strong tendon in the neck. That way, whenever you're turning your neck, it's kind of,
It's
if
not.
anything,
Yeah.
it might tug on that anchor, but not on the electrode itself. So that prevents it from like popping off, for instance. And then in the chest, it's sewn down to the muscle and a layer over the muscle called the fascia. And the breathing sensor is sewn in through, there's 5 different sutures there that kind of anchor everything in place. So normally it doesn't, but there can be issues in certain patients where, they turn a certain way and the device may move or cause discomfort. And, those are some of the things and some of the reasons why we may take people back to the operating room.
So from your experience, what would you say like the overall success rate is? Like if I sent you 100 patients, like how many of those do you think are, you know, 4 months in, they're happy and they would gladly recommend it to someone else who's failed at CPAP?
Yeah, absolutely. So, I mean, we've reviewed this in our own patients
Oh,
and
awesome.
published papers on it, things. So, it's in the mid 70% range in terms of success.
Okay.
Um, Now, what is success, I think, is the next question,
Mm.
because success doesn't mean cure. It has a very specific definition. Um, and there's can be some people who are not successful by this definition, but still meet the definition that you used of kind of they're happy with it, they do it again, would recommend it to a friend.
Yeah, that's what I would use.
Yeah, so that number may honestly even be higher. It may be 80% or in the low 80s. But when we're looking at success, we want the AHI to decrease by at least half and get below 15. So that kind of puts you into that mild range where your likelihood of, having a stroke or a heart attack or dying are going to be a lot lower. Most people are starting in the severe range or at least moderate, but many of our patients are severe. We want to get them into that mild range and decrease it by half. That's what we're talking about when we say about 75% or so of those patients can expect to get those results. We look at 3 different things. We look at the AHI
Yep.
improving. Like I said, we look at the sleepiness improving,
Yep.
meaning we typically use what's called an Epworth sleepiness scale,
Yeah, I know that
which is
very
a
well.
very, very well. Yeah, I'm
Yeah.
sure.
Yeah.
So we use that. We want that to kind of get into the normal range at minimum to drop by 2 points, but hopefully, below 10 or so to
Yep.
really feel like they're sleeping well. And then of course, adherence, just like CPAP, we want people to use the device.
Oh, yeah.
If we put them through a sleep study and they're successful, but at the end of the day, they don't turn it on, that's not really a true success. So those are the 3 things that we look at.
Okay. Oh, that's pretty good. Do you guys do any stuff with blood oxygen? That seems like a bit of a no-brainer to me. Once they start turning it on and they're going through the settings, like get them to wear a Bluetooth pulse oximeter. Pretty easy to do. You just put on your thumb, go to
Yep.
sleep, and then you could be, as you're going through the settings, you could be monitoring the improvements on the desaturations, the average oxygen level, that sort of stuff. Is this anyone doing
Yeah.
any of that?
So quite a few of our more savvy patients who I'm assuming would probably fall directly into your audience, really take it upon themselves to do this.
Yeah, great. I
As
love it.
physicians, and kind of the pathway as it's been ironed out right now, unfortunately, it doesn't incorporate that data in terms of finding the right settings initially. Of
Mm,
course, we do a sleep study at the end of all this, like typically a home sleep study, to see the oxygen levels and the apnea levels and everything. But I think it is super helpful for people to have some type of oxygen monitor, like a ring, or any of these wearable devices to monitor their oxygen, because at the end of the day, we're looking at the hypoxic burden, the
absolutely.
so-called hypoxic burden, and that's really what we think is probably driving a lot of these bad outcomes. And at the end, in the future, that may be even more important than the AHI numbers that we're looking at. So I think
100%.
I think there's a lot of improvement that we can still make in that space for sure.
How effective is the implant long term? And is there any maintenance or follow-up procedures required over the following years?
Yeah. Well, the device, like we said, has been out for about 10 years. So it was FDA approved in 2014. We now have data, in terms of the published data, the most recent paper tracked it over 5 years and found that it was just as effective at 5 years as it was at 1 year. So
Awesome.
we're going to continue to follow the people long term, but we certainly don't have 20-year data yet. But everything seems to point towards this being effective long term, especially given that it's we're able to change the settings. So if something changes over time, we could potentially slightly increase the settings or tweak the settings and continue to get a good result. Once you kind of had a good result, you're at your right level, you pretty much just stay there, and then you need to come back to get the device checked every 6 months.
Always.
Yeah, always.
Yep.
Any malfunctions that we want to look out for those. Again, those are rare, like we said, typically less than 1%, but they can happen. So we do a quick test of the device, make sure everything's functioning well.
Yep.
Typically that's a short visit that happens twice a year. And then we do have to monitor the battery life as well, because the battery, similar to pacemakers, lasts about 10 years.
Okay.
So after 10 years, we don't have to redo the whole surgery, but we do have to do another surgery where we'll just open up the chest incision, remove the battery, put a new battery in.
Would Inspire bill? Is it a cheaper cost?
It would be a cheaper cost, yes,
Yep.
because you're not replacing the stimulation lead or the breathing sensor lead in that scenario.
I'm not sure if you want any more business, but I imagine there will be a lot of people who will watch this video. Do you want to give yourself?
Sure. Yeah. You can find me online, Dr. Nord. I'm in Richmond, Virginia. And so, just Google's always your friend. If anybody's is looking for Inspire, but let's say you live across the country, they have a website that you can basically find and put in your zip code, and then you'll be able to find like somebody who's certified to do the procedure, or a sleep medicine doctor who is really familiar with it, and that might be a good place to start as well.
Awesome, and I'll put some information in the description down below, and also pin a comment with some contact information.
Thanks again.
Awesome, mate. Well, yeah, maybe we'll catch up again in the future.
Yeah.
This was really good. Had a lot of fun.
Me too. Thank you.
Have a great day. See you soon. Bye. G'day, mates. This video is sponsored by Sleep HQ. Upload, review, and share your detailed CPAP reports with anyone from anywhere. Visit sleephq.com and join our free community today.